Thank you for joining us for this Healthy Living event on understanding brain tumors and neurosurgery in older patients with frailty screening. Understanding frailty is crucial in managing neurosurgical treatment in older adults. Dr. Christian Bowers will also discuss the types of brain tumors and microsurgical techniques offered at Hurley Neurological Center, Mid-Michigan's Center for Brain and Spine Disorders. Dr. Bowers is the Director of Neurosurgical Oncology at Hurley. He is renowned for his frailty research. In fact, his frailty lab, which has more than 24 active research members, has already published 17 papers here in 2024. He has been invited to give 18 national oral presentations. He graduated medical school from Georgetown University, and after a residency at the University of Utah, he trained in skull base, brain tumor, and cerebrovascular neurosurgery in Seattle at the Swedish Neuroscience Institute. Dr. Bowers is dedicated to providing care to the underserved and has only worked at level 1 trauma centers. He is fluent in Spanish. You can ask Dr. Bowers questions during this live presentation by texting only, 248-935-2562, or you can ask your questions on Facebook or YouTube. If you are watching a rebroadcast, please direct questions to his office at 810-262-7030. Dr. Bowers?
Thanks. It's a pleasure to be here. So thanks for that introduction. Really excited to be in Michigan and to be in Flint. And we're going to talk about brain tumors today and also frailty, so my two kind of passions within neurosurgery. And so as we talk about brain tumors, it's good to group these into different categories, and we'll try to keep it fairly simple for people today. But essentially you have two types of brain tumors. The majority are brain tumors that are metastatic, come from other places, and as the lower right graph kind of shows, lung cancer is about half of those, then breast and melanoma and other types make up the other part of those tumors. Primary brain tumors make up the other quarter of the tumors that we deal with. And in general, the way that primary brain tumors can be thought of, that last remaining quarter, is malignant and non-malignant. So malignant meaning essentially cancerous, and non-malignant being benign. And I don't think we need to get into all the names or the different types, but that's how it breaks down, as about, of that 25% of primary brain tumors, you have non-malignant is about 3/4 of those, and the other quarter are the malignant types. And those are the types that people have heard of: glioblastoma multiforme, or GBM, the grade 4 malignant neoplasm. That's one that people have heard about a lot in the news, and reference with Kennedy and McCain having those, and those are common because they're such a common tumor. People have familiarity with that one. Non-malignant brain tumors, meningiomas, are extremely common, and a lot of people have incidental meningiomas or know somebody that does, and so we'll talk about those. But that's a good way to think of how to break it down, and when we're thinking about brain tumors in general. And so as we look at the brain, we have these different areas, and tumors tend to be predisposed to show up in the same kinds of areas, and so we get used to dealing with these types of tumors and knowing how to manage them based on where they present. And because those of us that go into neurosurgery, or those of us that are in neuroscientists or that enjoy the brain and neuroanatomy, know that different parts of the brain perform different functions, and a lot of times people will present with symptoms to the emergency room or their doctor because they're having, let's say, right-sided weakness from a tumor that's in the left side, the left motor kind of area that controls the right side, and vice versa. And so as neurosurgeons, neurologists, neuroscientists, those of us that are in these fields really enjoy the location. I often tell patients it's location, location, location. You can have really large tumors in the frontal lobes that don't cause problems because they're slow growing, maybe a giant meningioma, and patients don't notice it for many, many, many years. Or you can have a very tiny tumor that's growing in the brainstem, and it's very, very small and will cause way more symptoms than that very large one. So that is something that we'll talk about a lot today when we talk about treatment. Is it's not just the size, but it's the location, and it's also the speed with which the lesion is growing. So meningiomas, this most common brain tumor, they're very, very slow growing usually, and they can become very, very large for that reason. Whereas these malignancies, if they grow really rapidly, and so when they become big, it's usually the symptoms are much more acute in onset and have happened over a much more rapid time frame. And so that's a good chart, a good diagram to show what kind of symptoms are occurring based on where in the brain these tumors end up appearing. And one of the most common questions I'm asked is, how did I get this, when it comes to whatever brain tumor people are having or condition? And the answer is usually we don't know. Some people have these rare syndromes which are very well defined, but you don't see very often, such as a Gorlin syndrome or a Cowden disease, these genetic causes of tumors. And they show up a lot on our exams. We have to know all the details about them, but the reality is we don't typically see many of those patients. What's much more common is that we don't know the reason, or they're idiopathic, we say. But when we look at risk factors or exposures for these types of tumors, these are always ionizing radiation for whatever cancer somebody has. And then that's the proven kind of exposure. And then people are investigating all kinds of other reasons, from chemicals, alcohol use, cellular telephones, trying to find strong correlations with other things, but it's still, the jury's still out on all those. The one thing we know for sure is ionizing radiation and these specific genetic predispositions cause certain tumor types. So I think that's an important thing to know, is most likely if you come in and someone's found a brain tumor in you, or a friend or a family member, we won't know usually what the reasoning is. And so when we look at how big of a problem these tumors are, and these issues from brain tumors that affect the brain and other CNS system, the Central Brain Tumor Registry shows us, when you look at it compared to other problems from heart diseases, COVID-19, it's a smaller percentage, but when you have a brain tumor, that becomes a very big deal for you and your loved ones, and you want the best care possible, and you want to be able to get it dealt with and treated appropriately. And so when we are dealing with brain tumors, people have headaches frequently. It's very common for people to have headaches from time to time. And so people will always ask, how do I know if I have a brain tumor? And the reality is headaches are not all the same. They're very, very different. You have headaches, can be very acute and severe, can be brand new where you've never had headaches before. So that's a red flag, or something we want to know about and investigate further. They can be associated with fever or other systemic symptoms, and that's something that we also want to know about. It can lead us in a different direction when trying to figure out what is going on. Newer headaches, those that come later in life. You have headaches that occur with exertion. All these symptoms, if you have ones that come in the morning and the evening and that are better throughout the days, that's good to know. And a number of other symptoms that are associated with them. So these are all features. If people have headaches that are severe or persistent, if in young people or extremely older people, and if you have, the more of these red flag symptoms you have, the more interested we are in. It gives us an idea of where to work them up and to get them the scans done and try to figure out what's causing that. And so when it comes to brain tumors, people have these symptoms we've discussed. Maybe they're having headaches that are worse in the morning and in the evening. It's typical they're bending over to put their shoes on, they're getting worsening headaches. As we get an idea of this, we'll go and get neuroimaging. A CT of the head often is the first place we'll start with an MRI with gadolinium or contrast agent, since most tumors will light up on the imaging. And then if we have findings suspicious for a malignant brain tumor, then we will work it up and see if there's a metastatic disease. We'll often get a CT of the chest, head, and pelvis to look for other diseases if we think it's one of those. Remember, 3 of every 4 brain tumors comes from somewhere else as a metastatic tumor. So we'll look in the body for that. We can tell based on how they appear. A lot of times we can tell and have an idea what kind of tumor it is. And sometimes we'll do a biopsy. It really depends on where the location is and what symptoms somebody's having, what we think it is. And there's other times where we think we have a pretty good idea. It's pretty common that we would know what the tumor is, and then we would sometimes recommend going straight to surgery. It really depends on that constellation of your symptoms, what the imaging shows, and other factors such as frailty, which we'll talk about later on here in the talk. And then we will always, the thing you'll hear from me all the time is maximal safe resection. If we can take all the tumor out safely, that's wonderful, and that's what we want to try to do. But under no circumstances can we hurt you. So we want to take as much as we can without hurting the patient, and that's the key to everything we do and how we approach all the tumors and how we set everything up for the surgeries and what we're always focused on. And a lot of times, especially because the most common brain tumors you saw earlier for primary is meningiomas, we will come with a lot of patients that get referred to us with very small meningiomas that are completely asymptomatic. We have such access to MRI nowadays compared to and CT, we can get these very easily, and we'll find tumors that are not causing a problem. And that's called an incidental brain tumor. So if a brain tumor is incidental, it's usually a meningioma, or oftentimes a meningioma that we found based because you got in a car accident or slipped on the ice and hit your head. And so a lot of people will say, okay, well, what do we do with that? And so if someone doesn't have symptoms and it's a meningioma, these tumors will usually grow very slowly over a period of time. And so we'll usually repeat the imaging. A lot of times it'll be in 3 or 6 months, depending on how big it is and where it's at. And then as we start to spread that interval of imaging out, we will, I tell people, it sounds like developing a relationship. You will follow these tumors and you will, in essence, get to know them a little bit because we'll be following them for so long. And so as time goes on, you can spread that interval out where you're repeating the imaging. And then if it starts growing, I have so many patients that have meningiomas that are growing slowly, but they're also in the later stages in their life. And so I just tell patients, we're gonna follow this till one of us dies. So as we aim for forever. So which could be, the way these are growing, it could be do you plan on living to be 130? Because it could be that long. And so you're racing with these tumors until looking at the pace, where they're at, and what the size is. And I had many patients who are in their 50s, 60s, 70s, and we find a small meningioma, and I say, you're probably, the natural history of your life, I always ask them how long they think they're gonna live or wanna live, but we probably don't have to deal with this or treat it. I didn't always follow up all meningioma patients, even if I've spread their interval follow-up window very, very long down the road. I always follow all my meningioma patients for a period. But that is where this really matters as to how long we've been following it, where it is, how fast it's growing, if it's growing at all, and then that's how we base our management on it. Now, if patients come in and they're symptomatic, and the opposite of that would be someone with a very symptomatic, let's say meningioma in this case, tumor causing symptoms and they're young, well, they're not going to be able to make it, 70, 80, 90 years. We're going to have to deal with that sooner. So that's where we talk about the different treatment options of surgical removal, of radiation treatments, which can slow down the growth or even stop it sometimes, or a combination of surgery, radiation, and if it's a cancerous lesion, chemotherapy. And so it is a science of getting these tumors out safely and which techniques to use, but there's also a great deal of art, I would say, to the management of these and knowing the patient and knowing which are the best treatment modalities and taking all that into account. So making decisions on what to do with the tumors is extremely complex. I've had patients with small tumors that have grown a little bit, but they just can't stand the thought of them in there, and they really want to have surgery. I've had other patients who've had a tumor they're following that's growing slowly but not causing them problems. One nice thing as we get older, our brains atrophy a little bit and create a little more room, whereas young children, young adults have very, very full, tight heads. So sometimes as adults are aging and they have a smaller tumor, they're getting more and more room also as time's going on because these tumors grow so slowly. Now, it's very common for people to ask, one of the more common questions we get asked is when someone needs to have a craniotomy is, can I go through the airport safely and without setting off the alarms? And the answer is yes. So we use titanium, it doesn't set them off, and these are what we call snowflakes, little covers that go into the skull, fixate the bone flap to the skull, and we use little screws to fixate those, and that's kind of what it looks like in the diagram there, showing you the similar thing. We cut through the scalp. You can see the layers of the scalp there. We're starting with that antibiotic ioband at the top, then you have the skin, you go down to the subcutaneous or the fatty tissues of the scalp, and then there's layers of the scalp down to the bone. And we make holes. As you can see, the circular parts underneath those little metal covers, those snowflake covers, we make holes and then we connect them with the drill, what's called a foot plate router drill, and that's how we get the bone to come off, which that diagram is showing also. And then we open up the dura, it's like a thick leathery covering of the brain. We get access to the brain. We do the surgery that we're doing. Sometimes it's deep within the brain, sometimes it's on the surface. And then once we're done, we make sure there's no bleeding, everything has hemostasis, and then we close the dural layers. We put the bone flap back on top, like you see there, fixate it to the skull, and then we close the scalp. Sometimes if there's a muscle, like the diagram, we'd close the muscle first, if it's in this frontotemporal region, but that's that's how that procedure is performed, and that's very commonly asked of us in the office when we have to do surgery. These are just some pictures. In the operating room, we fixate the head. We oftentimes will use a GPS navigation type system, a stereotactic system, so that we load up special scans to that system, and there's a way that we can track. I tell patients it's GPS, it's the best way to think of it. As we trace on the head, it shows us right on the scan where the location is. And so we'll shave hair in the area typically, we'll cleanse the area, and then we'll kind of use that stereotactic navigation system to outline the dimensions of the tumor, what our incision is going to be, and then in brain surgery, a lot of times it's about getting safely in and safely out. So we have to create these windows, these bone windows, those craniotomies, like we just saw in this diagram. We create those over the area of where the tumor is to get to it. And so this shows, in this case, we did a craniectomy where we actually drilled away the bone, and then we put a metal cranioplasty or a cover on top of that, on that area. Cranioplasties are actually super interesting. Humans have been doing them for a couple thousand years going back. They found cranioplasty implants with the Inca civilization and even into Egypt, and humans have used all kinds of materials to cover defects in the skulls for many years, which is pretty amazing. And that shows you at the end, after we close the more superficial layers, we'll close the skin with a type of absorbable running suture typically, or sometimes staples. Now, sometimes we don't even need to do surgery, but we still need treatment. So stereotactic radiosurgery has really exploded as a treatment option. And it's actually not surgery, but we call it radiosurgery because it can be very, very effective, as if someone had surgery in these spots and control the growth or cause a problem of a rapidly growing lesion to dissipate or disappear, at least not continue to grow. And so in this case, the head is fixated. This is a system that doesn't use an actual frame. There used to be a frame-based system, and there used to be a non-frame-based system. But there's different ways of delivering the same result, which is you getting radiation treatment, and it's given in a bunch of different angles and directions. But the whole idea is that the radiation can hit the affected tumor area and then have a quick drop-off so the normal tissues are not affected. And so the smaller the lesion is, the more we can hit that lesion with the radiation and get that radiation to fall off and not affect the normal brain. And the bigger it is, the less that stereotactic radiosurgery becomes a good option. And if it becomes too big, then we don't use stereotactic radiosurgery, and we will do a more traditional fractionated radiation, where we just spread out that radiation overall dose over a period that's spread out over multiple doses and days. And there's all kinds of lesions we can treat with stereotactic radiosurgery. Small meningiomas, metastases are common. Those types of lesions. This is an example of a plan from a stereotactic radiosurgery treatment, and the center in the red is, you can see the gray is the measure of intensity of the radiation treatment. So that's a higher type dosage, and you can see as you get towards the outlying adjacent normal tissues, they're getting less of a strong dose, and we can mold how that radiation is delivered. We have amazing software nowadays that lets us do that and lets us mold how the dose is delivered to the area of interest. This is just a diagram that shows the locations of common types of tumors, where they show up at different parts of the brain. And as we kind of seen earlier, different tumors tend to show up in the same types of areas. And so we know, based on a patient's age, how the imaging looks, and where in the brain it is, we have a good idea of what tumors are. And that's a question I'm often also asked. Hey, how do you know this is X? I'm like, well, we know because I always tell people, you're never 100% sure, you're never zero. Well, we're really, really confident this is what this is because we've seen this thousands of times before. And so we start to have an idea or a characteristic based on having seen it so many times in so many different formats or versions. I also included this diagram because if you look at the skull in that lower right picture, in skull-based surgery, we're often dealing with lesions that are deep down and at the base, and we have to get to them by either drilling away bone or maximizing our angles, drilling away bone, and trying to safely get to difficult areas that are hard to get to because the brain's covering them. And so it's very common we deal with meningiomas of the skull base, and that's one of the challenges. Is it's a lot easier to deal with tumors towards the top and on the sides than it is to go deep down into the brain. And so that specialty, that training is about dealing with those deeper tumors and how to do that safely. This is just an example of a more giant tumor, and there's times where we like to do surgeries through very small incisions and small openings, and there's other times where we do them through larger incisions and larger openings. And this is a tumor that's very large. It has on the bottom images, you see there's a ton of edema or swelling around that tumor, and these are lesions that cause a lot of edema, swelling to the neighboring brain over them, and so you have to take them out in a way that doesn't exacerbate that. And so sometimes we'll occasionally have to do a very massive, large cranial opening. This is about as big as we ever do a surgery. And other times you can do it smaller. This shows getting all the way down along the base of the lesion and removing that with a maximal opening. And that's like the post-operative scan showing how that tumor was removed. There's no more residual tumor left. And we can see on that bottom view on the bone window how low we got along the floor of the skull base there to get to that lesion. And we didn't have to retract on the brain, so it was not extremely swollen afterwards. This is, I use a lot of these pictures in my clinic and when I'm seeing patients on rounds or in the emergency room. So these are on my Instagram account, because I'll just pull them up and show patients. But on the left side, you have a normal pituitary gland. And you can see above it, there's an optic nerve. So you have the gland sitting here and the optic nerve sitting here. When tumors start to get big in the pituitary gland and they start to push up on that nerve, it affects the visual fibers that cross over. So people have trouble seeing out here, bitemporal hemianopsia, trouble seeing out to the sides. And so we will look at these pictures with patients and show them, if it's up towards the nerve or just about to touch it or just barely touching it, doesn't necessarily mean you need surgery. I've followed patients like that for a variety of reasons many times. And if it is pushing on that, and we will have you be assessed by an ophthalmologist, and we'll see how your vision is, and that may be a reason to have surgery. So those are the factors that really matter with pituitary tumors. And I like showing people what the normal anatomy looks like on the left, and I like showing them what the tumor is doing, because a lot of what we do is very simple, to be honest. It's brain surgery, but you have a large tumor compressing a structure that's important. And so that's something we will address by surgery. We do a lot of decompression, whether that's in the spine from a disc fragment, or in the brain from a tumor, or in a trauma where there's blood that's pushing on something, or if someone has an infection in their spine or in their brain, it will cause buildup of pus that will push on things. So a lot of what we do as neurosurgeons is decompressing, one way or another, vital neurovascular elements, nerves or arteries that are critical. This is an example of showing how we use that GPS system I was talking about. You can see on the views on the right, it shows you where you are in the brain and where you're trying to go. In this case, they're trying to do a needle probe deep into the brain, and so they're showing the coordinates, but you have to make sure that the head is fixated when we do brain surgery typically, and then you register that, and that's kind of showing those angles, how that works. And this is a closer view looking in these different planes, showing you where we map out our lesion, and this just speaks to some of the technology we have. You see where your lesion is, and it helps you avoid the delicate, essential, critical fibers of the tracts in the brain that we have to preserve when we're doing surgery in the brain. So the technology's come a really, really long way, and we're really fortunate that to be able to do these cases here at Hurley, and that Hurley's invested so much in building this opportunity to have a brain and spine tumor center. So that's the first part of the tumor part of my talk. We could talk about, I give lectures to residents preparing for exams for over multiple sessions. That was kind of a quick rundown. The next part, my other kind of passion is really is about frailty and talking about how neurosurgery in an older aging population. And I like to tell patients, this is the one area we could tell patients, that kind of like world experts in, because we publish more papers than anybody else. And so I love talking about frailty and what it means. And I usually start by showing people pictures of these slides. And I say, what does this show? And everyone always says, somebody that's old. And I said, well, no, it's, when I was, this is from a subway in London, this picture. And it's not just the old person or the person with the cane, but you have a pregnant person, a person with a child. It's really not just about age. This is about those that are vulnerable. And that's really what frailty is getting at. And if we look at this from the New York Times last summer, but it's showing that the population is really starting to age over this period from 1990 to 2050, that 60-year period. A lot of the Western world is getting much, much older, and in Asia. And so all around the world, this is a time where the world's healthcare system is facing what we call a silver tsunami, or a massive wave of older patients. And so as a healthcare system, we have to be ready for that, because we are getting this huge wave coming. The silver tsunami is coming, and we have to be prepared to see a much higher volume of older patients. and have surgical decisions facing us in numbers that we never had before as a healthcare system. So this is a clinical frailty scale, and as I introduce this, I like showing this to people because this one you don't have to be a doctor for. If someone's out running a marathon, number one, and they're very fit, that is not a frail person. They're robust, we say. And that's true whether they're 50 years old running a marathon or even if they're 90 years old if they're running a marathon. But someone that's bedbound or is on hospice and can't move, that's kind of the very definition of someone that's very frail. And so this is a visual scale. It's not the scale I use, but it's a visual scale that is trying to identify this concept of patients who are more vulnerable or the opposite, patients that are more robust. And it really is dealing with this concept of reserve. And so why does frailty matter in surgery? In this diagram, let's say at the top, number one, you have someone that's robust and they have a major change in health status in the blue. They dip into this area where they might be vulnerable, but because if they're robust and they start really high, then they recover and they go back to their previous health status. And if they're robust, number one, and the red arrow comes, they have a minor change in their health status, they just take a little dip, but they're still in this independent, strong, robust state. Now, number two on that diagram in the middle, if you have someone that's frail and they have a major dip there on the dotted line, let's say a major change in their status, they may not make it back up to becoming independent. They might be stuck in the red, the disabled, or they can even potentially die from the results of a surgery that they couldn't tolerate, or an illness, or whatever that insult is, maybe a trauma. And so the whole idea with frailty screening is that we help patients and their families better understand the risks of surgery, and we want to identify the patients that are going to do worse with surgery. And so the frailty screening we use with the risk analysis index, we try to find this top 10%, this top decile, because we know that they are at the most risk, exponentially more risk with frailty. And for any sort of interventions, for we saw with COVID-19, major traumas, injuries, illnesses, all these things, you will always, if you compare the very frail to the rest of the group, the very frail is always going to do worse, and we usually divide it up into the robust, normal patients, frail, and then the very frail. And we can see a spectrum in almost every disease we study. I think we published over 90 papers the last 2 years, and they all show this similar theme: different outcomes, different diseases, but the very frail tend to do significantly worse than the frail, who do worse than the normal, who do worse than the robust. And so that is really at the essence of what our research is doing. And when we started doing this, we were basically setting the definitions for all these different diseases and trying to identify what the risk profiles were for all these diseases. And we feel that information helps us help patients and their families make better decisions with more precise information about what they should do with proposed interventions. And this just shows it's a review we wrote. I started as an attending. I'm just finishing 7 years, so I started in 2017, and we started doing this research during that period. And this shows the explosion of the frailty research and the publications during that time, because the population's aging, and this has become a more and more timely topic during that period. So when I started and I wrote the first review on frailty and neurosurgery, right as I first became an attending, there was only 25 papers on the topics, 20 on spine and 5 on cranial surgery, and then that's really exploded to consist of this much, much larger number. And this was just, during the introduction, this is just showing the growth of our particular lab and how we've written a large portion of the papers and how much our publications have grown over time. And to your point about the 18 oral national presentations was last year in 2023, but compared to the previous part of my career, we really kind of taken off as this has become more and more popular. And this is a little bit beyond the scope, but we don't need to get into all the weeds of this, but the frailty screening, we really like to assess what are called multiple domains. So traditionally, before frailty screening came in, people just used how sick is somebody. They have heart disease, diabetes, kidney failure. Those are called comorbidities, and that's one part of it, but now we like to assess for your nutritional status, your mobility. These are all the things when we use the risk analysis index there in the blue. It's a much more comprehensive, it covers more domains, we call them, domains of frailty, so we get a better sense of how the person is overall. And it has age built into it, so when we're calculating scores, we take into account the fact that the older individuals tend to be more frail as a whole, as a population, compared to younger patients. And so we add all those things up and we look at the score at the bottom, and the very frail tend to be over 40 or 41 or more, and 20 or less are the robust, and then the typical or normal patients 21 to 30, and then the frail 31 to 40 on that scale. And so it takes us about 30 to 60 seconds to sit down with someone and just go through the questions very quickly, and to score the patients. It does not take long. And all of our research tends to show, this is kind of the scientific graphs that are in a lot of our publications, but the basic idea is the dotted line is just random chance, and then we are trying to find risk factors that can predict outcomes. So when we first started doing this research, we took a very simple scale called the MFI-5, which said you get a point for diabetes, you get a point for hypertension if you take medications, you get a point if you have lung breathing problems, COPD, emphysema. And if you get a point if you were non-independent, and we would compare it to older age, because all the medical literature up until this period was always saying older patients do worse. And so what we showed is the more that these graphs, like in the green arrow, goes up and to the left, the better that it predicts outcomes. And so what we showed in that first round of papers for the first couple of years was if we used a frailty scale, even a very basic, or what I would think of as not a very good frailty scale, this MFI-5, just by looking at those conditions, it always out-predicted what all of medical science had used up to that point, which was just age for outcomes. I mean, in my training, I read papers that said if someone's over 65, you shouldn't operate on them. You should do radiation. But I did residency in an area where I grew up, where there was a lot of patients that were older, that were healthy, outdoors, very outdoors-oriented culture, and they did very well with surgery, which was kind of against what the medical literature said. And that's where I really got interested in this topic and this idea. And then as we have been using the risk analysis index the last 2 to 3 years, we have started, that's what's shown in the blue line, we have shown that that does even better than the MFI-5 does, and as it did compared to age. So that's kind of where our research has been going over the last 3 years, is using this risk analysis index and showing how much better we can predict adverse outcomes. And so we've been writing these publications with these big data sets of high quality data from the National Surgical Quality Improvement Program, where we're looking at 60,000 patients. Let's say the upper left diagram is from a surgery on a simple procedure, ACDF, but that risk analysis index caused a massively improved prediction of mortality with that surgery compared to the MFI-5 in orange, which was much better than older age had been before. So that's kind of the idea behind all of our frailty research, is trying to figure out how much worse this very frail group will do with surgeries, and that gives us a lot of information to talk to families about when they have a proposed surgical intervention about, well, why wouldn't I do surgery? Well, if you're 95 and you're frail and you have all these health problems, these are the reasons why surgery may not be a good idea. Because if it doesn't, you're at a very high risk for a complication. And or we say if it's surgery that has to happen, or in terms of what the patient and family want, how can we mitigate risk? And that's really where the research is going to be taking off. Can we prehabilitate that patient? Can we get them into a physical therapy regimen to get them stronger for surgery? Can we create a special post-operative regimen to watch them differently than more patients? The idea, though, is to identify those patients that are at more risk, and what can we do to do risk mitigation with those patients? That's really the heart and the concept of this. In conclusion, we want to just tell everyone that the Hurley Neurological Center is here at Hurley Medical Center to help with any neurosurgical problem that people have, and we can handle the spectrum of neurosurgical diseases. And we would be happy to see anyone with a brain tumor or give someone a consultation that would request that, and we can get you in right away and get you evaluated. And we have lots of management strategies with brain tumors besides just straight surgery. The majority of our tumor patients will watch, because we have a lot of benign disease with meningiomas or pituitaries that will watch for a long time. And back medicine many years ago would kind of tell patients what to do, and now we have so much information, we will educate patients and give them options and give our recommendation. And so it's nice as a physician to have that opportunity to kind of help educate patients and their families. And I believe this frailty screening is a massively important part of that. And as we all get older and older, family members we're taking care of, or they have health challenges, it's really nice. I think the population in general is going to have to think about more of this frailty when it comes to decision making about their loved ones and what to do.
Well, now is the time to get your questions answered live. You can still ask Dr. Bauer's questions by texting 248-935-2562 or submitting questions to Facebook or YouTube. Melinda, as actually asked something that you just mentioned. What options are there besides traditional surgery?
So one of the things, so when you have a tumor, the first question is, and we're talking about tumors, I'm assuming, the first question is, when it comes to options, do we need to even treat it? Can we just watch it? Can we just watch the tumor and re-image it? Because if it's incidental, that's typically what we do first thing. When it comes to if we decide we have to treat it because it's growing, it's causing symptoms, whatever the reason may be, then you have surgery, traditional surgery, and you can do that through different methods. Or you have what we were talking about earlier, radiosurgery, where you treat it with radiation. And there's different ways of delivering that as well in different systems. And so those are kind of what they end up being predominantly. Sometimes we don't know what a tumor is and we can biopsy it. And if it's deep, we'll use that needle kind of method we showed earlier. And that's typically what we do if there's something we're not sure if it's cancerous or what it is, and we're trying to make up a plan. If it's deep, we would do a biopsy and figure that out.
Gary's 31-year-old son had a brain tumor removed about 1.5 years ago. He's had radiation and chemo. He says he knows that there's no cure, but he's wondering if there's any new treatments that are showing promise.
It depends exactly on what type it is. If you're getting the chemotherapy, then we're talking about a brain cancer. And we just talked briefly about glioblastoma, just for the scope of this talk with the general public. We didn't go into all the different types, but there are clinical trials, and it's always good to come see us, and we'll take a look at what you have, what type of tumor it is, and what clinical trial options are available.
And it just brings up a good point too about second opinions. I mean, you guys are available
absolutely, yeah,
at the center for that. And
yeah, we're happy to see anyone in a second opinion, and happy to see anyone and chat about that.
Cindy says her mom and grandma both had brain tumors. She wants to know if they're hereditary, and if so, should she get screened?
Yeah, so tumors can run in families. We showed earlier there's some genetic predispositions, but I think the easiest is come see us and give us your history, and we'll look at it with you and decide if it's worth screening. But very rarely do we just screen across the board for tumors. There are some situations, but they're fairly rare.
This question came in by text. Are you finding more of these are congenital as diagnostic imaging advances?
I wouldn't say necessarily congenital, but we find much more incidental tumors that we talked about. The slip and fall, the fender bender, someone hits their head, where we scan somebody and then we find a tumor, and in those settings it's almost always universally benign because we're just finding it randomly, whereas like if it was malignant, we would have found it typically while they presented with symptoms.
Judy says in 2018 she was diagnosed with small meningioma. Should she get checked again to see if it's growing?
2018. And it hasn't been imaged since?
No.
Oh yeah, we generally, if it was just a one time, I always see those patients back with imaging just in a shorter interval at first to establish that it's not growing a little more quickly. The vast overwhelming majority of these meningiomas are these grade 1s, but there is like a 7 to 8% window that are more aggressive grade 2s or grade 3s. So I always like to image them and make sure that they actually are these, most likely these grade 1 meningiomas. They're not growing at all in that short interval.
And our last question is from Melissa. She says her 73-year-old father has had severe headaches for several months. His doctor says headaches are common for seniors, so he's just been medicating him. She's worried it could be a tumor. Should she push for testing?
I think the primary care physicians, if it's someone that is taking care of your family and they know the patient, I like to go with what the recommendations are. Eventually, if they're still having that, they'll continue to have symptoms, and I think your primary care physician, if you just have that discussion with them, they would recommend a scan at some point if the headaches persisted or they seemed abnormal. So they're used to seeing lots of patients with lots of complaints of headache, and they typically will have an algorithm, but we're always also happy to see somebody and provide some reassurance. And I don't think most primary care physicians in that scenario I've never had one of them be upset. I would get an image and then call them, and they would generally be appreciative of that in that scenario.
Okay. Dr. Bowers is taking appointments at the Hurley Neurological Center, Mid-Michigan Center for Brain and Spine Disorders, 810-262-7030. It's centrally located in Fenton, positioned to give patients statewide access to specialized care for complex issues, as well as second opinions on spine and spinal cord injury. cerebrovascular neurosurgery, neurosurgical oncology, and skull-based surgery. We do thank you for joining us. Hope it gave you some great information to help you on your health journey. We also thank Mid-Michigan Now for being our broadcast partners today. You can always head to hurleymc.com for more information. Have a great day, everyone.